Hi, I am Peter Glowicki from Mayo Clinic, Editor-in-Chief of the Journal of Vascular Surgery. I am happy to bring you the highlights of the very best papers we assigned to the July issue of the JVS. The Editor's Choice article this month is a new SVS practice guidelines with recommendation for follow-up after vascular surgical arterial procedures. The guideline committee was chaired by Dr. Gene Zierler from the University of Washington in Seattle. This is an important document that was thoroughly reviewed by the SVS Document Oversight Committee led by Dr. Tom Forbes. The document includes useful recommendations on follow-up after a wide variety of open surgical and endovascular procedures. After carotid endarterectomy or carotid artery stenting, the guidelines recommend surveillance with duplex ultrasound at baseline within the first 3 months, and every 6 months for 2 years, and annually thereafter until no restenosis is observed in 2 consecutive annual scans. The strength of recommendation is strong, and the quality of evidence is B, moderate. The guidelines recommend contrast-enhanced CT scanning at 1 month and at 12 months, and then annually after TVAR for thoracic aortic aneurysm. If the 1-month CT scan detects an abnormality, a repeated CT scan at 6 months should be considered, and the strength of recommendation is 1, that is strong, and the quality of evidence is B, moderate. The committee also recommends CT scanning with or without contrast enhancement at 5-year intervals after open surgical repair for thoracic aortic disease, with a strength of recommendation that's strong and a quality of evidence that's C, low. Contrast-enhanced CT scanning is recommended at 1 month and at 12 months after EVAR, with consideration of more frequent imaging if an endoleak or other abnormality of concern is detected at 1 month, and the strength of recommendation is strong and the quality of evidence is B, moderate. Duplex ultrasound is recommended at 12-month intervals as alternative imaging surveillance after EVAR if no endoleak or second enlargement was detected during the first year. The strength of recommendation is 1, that is strong, and the quality of evidence is B, moderate. The guidelines recommend total aortic imaging with non-contrast enhanced CT scanning at 5-year intervals after open surgical repair or EVAR to detect aneurysmal degeneration of other aortic segments. And this is a strong recommendation with a low quality of evidence. Additional key recommendations on follow-up after thoracic aortoiliac, infrainguinal, mesenteric, and renal reconstructions are also included in these guidelines that should be consulted by all physicians and healthcare professionals who participate in the care of vascular patients. The next paper I would like to introduce to you is our CME paper for this month. It is entitled Comparison of Access Type on Perioperative Outcomes After Endovascular Aortic Aneurysm Repair, written by Dr. Jeffrey Syracuse and colleagues from Boston, Massachusetts and Gainesville, Florida. This is a retrospective analysis of prospectively collected VQI data. In 8,340 patients, 64%, endovascular aneurysm repair through a percutaneous approach resulted in reductions in operative time, estimated blood loss, and postoperative length of stay, compared with results in 4,747 patients who underwent abdominal aortic aneurysm repair by open surgical access. The percutaneous approach failed in only 4%. The risk was higher with the previous bypass procedures, ruptured aneurysm, general anesthesia, female sex, obesity, coronary artery disease, and preoperative aspirin use. Now, these early results suggest that a percutaneous approach should be used for endovascular aortic aneurysm repair whenever possible. The next paper I would like to introduce to you is an international collaboration on Gore iliac branch endoprosthesis for treatment of bilateral common iliac artery aneurysms, written by Dr. Tom Maldonado and colleagues from New York and Brooklyn, New York, with co-authors from Spain, Italy, the Netherlands, and the United States. Now, in this retrospective multi-center registry study, 47 patients who underwent endovascular repair for bilateral common iliac artery aneurysm using Gore iliac branch endoprosthesis with a technical success rate of 98%. There was no mortality, there was no morbidity. Radiographic follow-up imaging at a mean of 6.5 months revealed no type 1 or type 3 endoleaks, no second enlargement, and no device migration. There were no new cases of impotence, and there was one new onset buttock claudication related to an internal iliac artery branch occlusion. Results of this study suggest that preservation of bilateral internal iliac arteries during repair of bilateral common iliac artery aneurysms can be performed safely with excellent technical success and short-term patency rates using the Gore iliac branch endoprosthesis device. The final paper we would like to call your attention to is entitled Quantitative Analysis and Predictors of Embolic Filter Debris During Carotid Artery Stenting in Asymptomatic Patients, written by Dr. Michele Piazza and colleagues from Professor Grego's group in Padua, Italy. Now, this is a prospective single-center cohort study of 278 patients who underwent stenting for asymptomatic carotid artery disease using a filter. The authors found that embolic filter debris was present in 74% and over 12.5% embolic filter debris load predicted ischemic complications. Age over 75 years, plaque length over 15 millimeters, hypoechogenic plaque, and pre-existing ipsilateral cerebral ischemic lesions were factors associated with clinically relevant embolic filter debris. The authors therefore concluded that 3 out of 4 patients will have emboli during carotid artery stenting, and patients should be aware of this risk. This paper just adds to the large body of evidence that embolic protection should be used in all patients who undergo carotid artery stenting. Now, these were just a few of the many excellent papers from the July issue of the JVS. Please download each of these articles free. To access them, please visit us on www.jvasksearch.org. Enjoy reading all JVS journals and let us know, please, if you have any comments or suggestions, and have a great summer. See you next time for the highlights of the August issue of the Journal of Vascular Surgery.